All right. Well, thank you, everyone. Welcome. We are please come in. We are very lucky to have with us today Professor Shauhin Talesh of UC Irvine. Professor Talesh has a range of skills and interests and scholarly production that is rarely matched, actually, in the legal academy. His work spans law, sociology, political science. What I would say is he knows a ton about a ton of different areas of law. His research interests include empirical study of law and business organizations and dispute resolution, consumer protection, underscore, insurance, also underscore, and the relationship between law and social inequality. And if that sounds to you like a pretty broad range, that's what I'm talking about. Professor Talesh is considered one of the leading scholars on particular aspects of insurance law. And when you map that onto the breadth of his knowledge and interest and research into social systems and inequality, you understand why we have asked him to join us this year as Berkeley Law's own William T. Barker Distinguished Visiting Professor of Insurance Law. And so he taught a class this semester on insurance and inequality, and the heart of his work on these issues has been the topic that he will be addressing today: health insurance rights and healthcare access for trans people. Above all, I suppose, there are two other things you should know about Professor Talesh. One, that he is a graduate of our very own JSP program. And two, and perhaps most importantly, he was in the very first class that I taught at this law school so long ago that people can hardly remember it. Without further ado, it is wonderful to have you here, Shauhin. Thanks for joining me.
Thank you so much, Ted, for those kind remarks. And thank you, Ben, for helping coordinate. And thank all of you for attending. Thank the Consumer Justice Center out there. It's doing wonderful work for sponsoring and hosting, and the student groups that are co-sponsoring. So it's a real privilege to be here virtually. So I'm excited to have this opportunity to talk with all of you. And I'm going to present a paper that's recently published in Law and Society Review. And it's a collaborative project with Anna Kirkland and Angela Perrone, two women's studies scholars that we collaborated together on this project. We benefited from funding from the National Science Foundation for this project. And we published already an article in the journal Transgender Health on health insurance policies and trans-related care. And this paper that I'm going to present today is more the qualitative piece of the project. So we get into sort of the experiences of the lived experiences of those seeking care. So like Ted did a really nice job, actually, of sort of highlighting broadly my research agenda. But in general, I study how private organizations respond to legal regulations and what effect these responses have on civil and consumer rights in terms of procedural fairness and substantive justice. So I sort of study how law lives within organizations, and then how these constructions of law bubble up into and shape law among regulatory institutions and even shape legislation. And so this paper in particular is very consistent with my research agenda on law and inequality, law and social change, and the role of organizations. And broadly, this paper is really about whether we think law can produce social change, okay? And as we know, there's been a raised rights consciousness, if you will, over an awareness for transgender rights in the past 5 to 10 years, thinking about bathroom access, employment, sports, and healthcare. It's been much more in the discourse. And of course, the Affordable Care Act plays a big role in that, right? It prohibits nearly all healthcare entities from discriminating on the basis of race, sex, color, national origin, right? And Section 1557 highlights a specific provision that says that there's a right to be free from sex discrimination in healthcare. And of course, the implementing regulations under the Obama administration define sex more broadly than traditionally in the past, right? An individual's internal sense of gender, which may be male, female, a combination, or neither. Um, and so, while these are considered important interventions in the ACA, they also ban categorical exclusions as relating to trans-related care, as related to gender transition. But they allow insurers the discretion to determine medical necessity, and that's the quote down here on the bottom. Nothing in the section is intended to sort of restrict an insurer's ability to sort of set what constitutes and what is medical necessity. Okay, so that's sort of the broad backdrop, right? And then of course in 2020, the Trump administration issued new regulations for Section 1557 that narrowed the definition of sex to the more traditional biological binary of a male and female. And then 3 days after that, Bostock v. Clayton County came out, and of course held that sexual orientation and transgender discrimination are covered by the Title VII ban on discrimination on the basis of sex, right? So there's just been this jostling back and forth. And of course, then Biden took over and he went back to the regulations, to the definition and the regulations that you're seeing here on the screen. So this project in some respects sets up a classic law in the books versus law in action situation, right? Because although the ACA and Bostock highlight how law is increasingly embedding rights in legal institutions for transgender persons, it's an open question whether these laws can produce the desired social change, impact for transgender persons who seek medical coverage through their health insurance. And so that's what this project is trying to explore. As I put the research questions, on the slide here, it's really trying to get at, look, how do transgender people and healthcare intermediaries or allies navigate the health insurance process and contest the meaning of medical necessity in coverage determinations, right? And so we broke our research question into two sub-questions. We're looking at sort of how actors in the transgender field, and we define it here, construct the meaning of medically necessary health insurance coverage, and what impact do these constructions have on the delivery of care to people, right? So in other words, how does it matter, right? And our project has a theoretical backdrop, right? We're not the first to kind of engage in interest in these topics more broadly, right? There's existing empirical research on trans people's experience with health insurance, and they've identified a series of individual and structural barriers, but they haven't focused as much on the construction and the implementation of medical necessity among healthcare actors and how that impacts people's access, right? Sociolegal health scholars have highlighted how patient and provider contestation of insurance coverage, and they've also looked to some extent at the role of medical necessity, right? But they haven't looked at this in sort of the trans health context. And so we're sort of integrating these literatures together, and in doing so, trying to fill in some gaps, right? We know that people have talked in the past about how insurance acts as a form of regulation, but we're exploring sort of the mechanisms through which policy language, interpretation, implementation can influence access to care. We're also looking at the focus on health insurance here, and in particular for transgender rights, is sort of a site of conflict, right? So we're doing a deep dive into this sort of intersection between insurance and transgender rights. And all the while, this is very much the paper, if you had a chance to look, or you can read it later, is very much a story of mobilization, right? It's not just that trans persons are seeking care, they're mobilizing their rights in really interesting ways. And so we're sort of filling these gaps as we go forward. So, this is an empirical project, right? It took a couple of years to sort of produce, if you will. And I want to talk briefly about our methods. One, we used some of our NSF funding to purchase access to health insurance policies and contracts. We purchased approximately 1,500 health insurance contracts, and the summary plans of these. We did a deeper dive focus into sort of California and Michigan as sort of, sampling a couple of states. And we chose these states in part because both include some explicit legal protections for transgender health, but to varying degrees, right? Both have categorical bans on insurance exclusions for transgender health, but California takes the additional step of providing transgender inclusive health benefits for state employees. We had a large research team of grad students and even some law students actually, and undergrads actually, who coded all these documents. And we went through a pretty elaborate coding scheme, but really the bottom line is we were looking for the existence of a non-discrimination clause in the contract, whether gender identity or sexual orientation were included. We coded for the absence or presence of the WPATH, or the World Professional Association of Transgender Health recommendations for transgender health benefits across 52 discrete elements. So WPATH is sort of an international body of experts, doctors, sort of stakeholders that have some knowledge here in the space to offer recommendations. And we were sort of coding to see the absence or presence of these things. We also coded for the types of exclusions that might be relevant to those seeking trans health related care. We coupled that with interviews with transgender and non-binary adults who have recently experienced health coverage and sort of engaged insurers. These were individuals who were over 18, who sought some insurance since 2017, were willing to talk to us about their experiences. And we coupled that with interviews with what we can think of as sort of intermediaries or allies, surgeons, clinical workers, and office administrators who work with transgender and non-binary patients. And then, of course, I have my catch-all here at the bottom. In doing all this, we follow the standard procedures and protocols for social science research. That sort of code for saying, we did this very thoroughly, we didn't cut corners, we were rigorous, right? So, and rather than have 3 more slides showing that and suck up all my presentation time, you sort of got to sort of take my word for it. Okay. So let me talk briefly about the insurance policies before going into the qualitative data. So in sum, I'd say, look, our analysis of the health insurance policies reveals that although outright exclusions are far less pervasive, insurance policy language remains confusing and difficult to understand, and it actually empowers insurers to cloak coverage decisions and make it hard for enrollees to know what their entitlements and rights are. So, the vast majority, there are only a few policies that we located that still contain categorical exclusions. And of course, they're not supposed to, but the vast majority don't have categorical exclusions. So that's a good thing, but they exclude specific procedures like facial confirmation surgeries, breast augmentation, etc., despite them being recommended by WPATH. Okay, so in addition, there's often confusing and sort of mixed messages and difficult to understand language as to whether there's coverage or not under these health insurance policies. So, quite often these health insurance contracts, about a third, a little over a third, were silent as to transgender coverage. Okay, so they may or may not cover, but they don't sort of say. So it leaves a real ambiguity in the language, or they would bury the coverage in another provision. So let me show you an example here. California Kaiser Permanente plans that we looked at didn't mention gender dysphoria coverage, but note in a section about travel expenses that reimbursement would be covered for specialty services such as transgender surgeries. So, they don't have an outright explicit mention of coverage, but they sort of bury it implicit in the reimbursement context. Sutter, a very Northern California-based health plan, mentioned that penile prosthesis would not be covered except for trans-related health care, but it lacks a section affirming transgender care in general, right? And so this is what we found over and over. So this mixed message and sort of confusing, it's ambiguous, it's not clean, right? And one has to wonder whether that's intentional or not. And then we coupled that again with the qualitative research, right? And so looking at sort of how contestation over medical necessity is shaping people's experiences with healthcare. And so really there's sort of 4 big, broad findings that I'll dig in on each of these. One, the meaning of medical necessity we uncovered is socially constructed by various actors who seek and work in transgender healthcare. And this leads to sort of 2 different meanings or definitions operating in the healthcare field, if you will. 2, insurers use discretion afforded them, and I showed you that discretion on that first slide, with the term medical necessity to impose actually rules and restrictions that throw up additional barriers for trans people. And I'll show you that in a second. Third, trans people are not sitting idle. They're engaging in individual and structural mobilization responses to contest these denials. And four, healthcare allies, if you will, are contesting medical necessity using tactics relating to billing and coding processes, mental health referral letters, and appeals for insurance denials, right? So these are sort of the mechanisms or techniques or pathways where the contestation takes place. Okay, so first point, social construction of medical necessity, right? In the transgender context, what's considered medically necessary is socially constructed in really different ways, and this contestation leads to two different meanings of law. There's sort of a narrow view and a broader view, right? If it's medically necessary, it's covered. If it's cosmetic, experimental, it's excluded. The insurers view it more narrowly. Medical necessity is a procedure if there's a medical procedure is medically necessary if there's a physical functional benefit. Need to see an improved physical functioning or reduced cost of the medical burden. Doctors, therapists, allies view it differently. It's whether the procedure improves the well-being and quality of life for the person, including improving the mental health of the person. The context, and that's an important word here, of the procedure really matters. So you see these two different views come out of our interviews. And here's a nice quote here for one of the doctors we interviewed that really makes an important point. The distinction for me between a cisgender and a transgender woman is the medical condition. I'd argue there's no particular procedure that's inherently cosmetic or reconstructive. It's the diagnosis for which that procedure is being performed. Insurance companies have simply chosen to view gender dysphoria as cosmetic, right? And of course, this has important implications because this functional view leads to inequities because this particular population of patients have unique needs. Many don't feel like they're in the right body, if you will. There's a high suicide rate. Facial confirmation procedures, these specific procedures that are sought are often considered vital to their mental and physical security and decreasing the chances of stigma or violence or discrimination, which are very real, as we know. So you can see how this construction can really have an impact, right? And so, this example here, I have many examples in the paper. I just sort of give you a flavor in the presentation here. This is a nice example of how this narrow construction creates a barrier. So the laser hair removal example, right? So surgeons often require laser hair removal from the genital area before transition surgery, so that the final result doesn't leave hair growing in undesirable places. Now, it turns out insurers often do not cover laser hair removal because it's not medically necessary. Okay, so here's a take from one of the people we interviewed on this exact point. This came up multiple times. Hair removal, this is huge. Genital surgery often covered. What's not covered or treated as medically necessary is hair removal at the surgical site. That's like bonkers, like straight up. It's part of a medically necessary surgery, but I can't think of any insurance companies right now that are covering it. Our plastic surgeons write a lot of these letters saying it's part of a medically necessary surgery. You need to cover this, right? So you see this construction really creates, attention in the field and has real life implications. Another big point that came up related to this is the definitions of medical necessity were often confusing and frustrating. And patients we talked to, trans people we talked to, wanted clearer or broader definitions. And more importantly, they want to change the discourse and language around medical necessity, right? And this is a long quote, but it's an important one. And I'm just going to highlight the red part. That looking at things as medically necessary, that's super important because that changes how it's written and how it's talked about. I think what the problem is a lot of healthcare that trans folks are seeking is trivialized and thought of as, cosmetic, which is a way for them to say it's not necessary. And if you change the language about it, you change how it's talked about, and you recognize, that things are medically necessary. So this battleground over discourse, over language, and over understanding is very real on the ground here. As I said earlier, there are sort of rigid rule-based requirements that make qualifying for medical necessary treatment on the basis of gender dysphoria for trans persons very difficult. For example, and so you say, well, okay, so show us what you find here. And so I'll give you some highlights here. They often fail to follow WPATH guidelines and recommendations, often require more than WPATH. Additional documentation for letters. So instead of needing one mental health letter confirming that the person, really needs this procedure, they often require two. Okay, and this is a clinical social worker here that's expressing a lot of frustration. The insurance criteria for surgery, they model it after WPATH, but they don't follow it. I recently had a patient for chest reconstruction. WPATH says you need one letter. I've had 2 Blue Crosses say we need 2. We've tried fighting that; it's not medically necessary. And often, we found that patients often what's called lump it and choose to comply rather than fight. So even though they could probably try to fight the fight here and maybe get it down to 1 letter or contest, they just sort of try to suck it up and do it. And that's considered sort of lumping. You're lumping it. You're giving up your rights, or waiving your rights in some sense. A couple examples: the age, gender transition age limit was often an issue that came up. WPATH says 18, but discretion to account for individual needs of a person. Many policies said 18. Some even said 21. And that was an issue. There were often long mandatory waiting periods or verifications for procedures, and I put here what I term worthiness causes. So, rather than having to wait 6 months for your procedure, the insurers would make you wait 12 or 18 or 24 months. Sort of, do you really want this procedure? Then you're willing to kind of wait it out. Sort of, are you worthy of needing this procedure? And of course, that doesn't account for the financial cost of this procedure. Another barrier that we were surprised to find was a very real one: is geography. So in many parts of the states we were studying, there's a lack of available doctors and mental health professionals. Of course, we need these letters, right? In geographic areas. And so many patients often had to travel 4-6 hours in a car. I think even one said 8 to get to an appointment, right? There are also sort of intersectional issues along race and class that we touch on in the paper. That all of these throw up, a lot of these are rigid rule-based and throw up a lot of barriers, make it harder for patients to access their care. This is a quote here that just, I won't read this quote, but it just underscores this point about the arbitrariness of having a number like 18 when a person is 17, right? This person is 17, they're not 18. Do we really think they have a lower suicide rate because they're 17 and not 18? I don't think so. Here's the insurance company. They're supposed to be helping, but get the services they need so that they're healthy. I think it's a ruse. I think it's a cover. And this person was frustrated that the marker of 18 was being used to exclude people who are 16 or 17 and wanted transition-related procedures. So then, the third sort of bullet point that I had showed you 4 bullet points. The third one was about the resistance, the mobilization, right? Trans persons are not just sitting idle, they're mobilizing, right? And they mobilize across 3-dimensional ways: individually, structurally, and sort of what we call intermediate approaches, right? These are some of the examples in the paper. Again, sort of digs into some of these, or all of these actually. They engage, they often will seek additional jobs or multiple jobs or switch jobs, take on credit card debt, switch insurance plans, or even, stockpile hormones after encountering challenges with coverage, sort of load up so that the next time the insurer plays hardball, they have something to fall back on. Structural mobilization included sometimes contesting or fighting the insurance company, as I mentioned, not lumping it in that case, but actually fighting and pushing insurance companies to clarify their documents and language, or evolve their policies, or often working with nonprofits who could mobilize on behalf of patients, right? And then there was, I think, a really interesting area, and one I would love if I had greater access to explore, is the intermediate approaches, right? This sort of informal information exchange and interpersonal sort of interactions with other transgender patients. And this would occur online, through social media networks, right? So there's sort of an informal transference of information in social media circles or online, and to help navigate, to sort of transfer knowledge, right? To help navigate this process. And I thought that was really interesting to see that it's a very real approach, and it's consistent with this sort of technological pivot that we moved to, that people are helping each other through social circles, and often electronically. So that's the third sort of highlight, if you will. And then the fourth, of course, is the intermediaries, the doctors, the clinicians, the counselors often engage in contestation over medical necessity, in a various different ways that really do shape the disputing process. One example was how they code, how you code what services you're providing. Because when the insurance company gets it, they receive a series of billing codes and they're either going to approve or not approve the codes. But creative coding was often considered a pathway to medical necessity, right? But the challenge was, of course, not to violate the physician's ethical or legal duties, right? So it becomes one of those things. There's a lot of gray zone. On the one hand, you want to advocate for your patient. You want to try to help them to the maximum extent, achieve coverage for the surgery that's appropriate. On the other hand, you can't lie or defraud insurance companies. And so, like I said, our team's pretty good. Our team may err on the side of overly strict kind of, totalitarian side of things, but it's an issue. The coding is very imprecise, right? And a lot of people talked about this creative coding, and that's sort of a term we came up with, but that's really what's going on here. But always dancing the line of legal and ethical obligations, right? This is coupled with, the other point here is the careful letter writing, often by mental health specialists for documenting gender dysphoria. And the informal network among social workers and therapists. And so this quote here does a nice job of highlighting these last two bullet points very nicely, I think. Here's a social worker talking to us. I know what the insurance companies want to hear and need to hear, and I write what they want to hear and need to hear. So we ask, of course, what do they need to hear? And that the patient checks those boxes, if you will, and I give as little information as possible. I don't want them to sort of glom onto anything that I said to use it to deny care. And this is how I teach other people to write letters as well. Like, let's keep it short and simple, basic, outline, they met the criteria, and keep it moving, right? And so this highlights the sort of point of the careful letter writing and, of course, the informal referral network. There's sort of an informal network here of communication and dialogue among social workers and therapists as a form of resistance. Right. Finally, in talking to the doctors, it was interesting talking to doctors who don't have a JD, but really in these appeals letters, you see the legalization of medicine taking place, right? You see these physicians invoking law-like terms, right? They didn't sit through 1L. They didn't have the great Erwin Chemerinsky for common law, but they are invoking law-like language and sort of engaging in quasi-lawyer behavior, if you will. And so I thought that was another interesting form of contestation. So, in sum, the implications of the work, I think, come back to the beginning of the talk, right? I said this paper really is about whether law can produce social change, right? And so, look, formal law is improving, but intermediaries impact law's capacity to produce social change on the ground. Insurance companies, as an intermediary, are impacting law's capacity, Bostock, ACA, raised rights consciousness, to produce social change on the ground for those seeking care, right? There are barriers that we identify, right, that include policy language, silences in the policy, interpretive disagreements, contested experience, right? We note that there are agents of resistance, doctors, therapists, and administrators, and I showed you some of that. We also note that trans patients themselves are resisting, right? But they have to mediate or navigate through multiple and interlocking institutional barriers, right? Intersectionality, geography, legal barriers, medical barriers, definitions, etc., right? One thing that came through the data and the people we talked to was a real sense that WPATH, for the most part, is doing a pretty good job, but we need insurers to follow WPATH's recommendations, which isn't happening enough. Of course, we need greater transparency for all health insurance plans sold without differential treatment based on ERISA preemption, which of course shields lots of liability for state claims. And we need more transparency and knowledge in how the insurance denial appeals process works, which would be another entire study. So that's the project. And I'm happy to take any questions. So thank you for listening.
I think Shauhin can see me if I stand here. Thank you so much, Shauhin. That's an absolutely compelling presentation. Questions, comments, thoughts that you have?
I have a question. I don't like shout.
Let's see if he can hear you.
Can you hear me?
Yeah, now I can hear you. If you stay at that volume, it'd be great.
Stay at this volume. So I did some similar research to this, like quite a while back, in France and kind of how their healthcare system treats trans individuals in regard to reimbursement. And I was curious if you've done any research on this in terms of like Medicaid patients, and seeing not just health insurance companies, but seeing how these things are reimbursed on like a state level.
So, Ted, if you don't mind, I heard everything up to I was curious, and that's where the question came. So, is there a way you can restate the question?
How do governmental entities like Medicaid or Medicare handle this sort of funding question?
Great question. They have various guidelines that they have to follow. So, I mean, that's essentially the answer. Is they have, guidelines coming from the federal government. They tend to be a little better about providing coverage. So there's less denials through Medicare, Medicaid, and that's in part because hospitals that are engaged in care through Medicaid and Medicaid and Medicare have lots of incentives, financial incentives to follow the guidelines that are articulated by the federal government. So whereas private healthcare companies or hospitals, if you will, have, there's a lot more discretion. So I'd say, Medicare and Medicaid are pathways. It's a little more bureaucratic, surprise, surprise, government. But the benefit is that, that they're bound. If you're going to use Medicare or Medicaid, then the insurers are a little more bound and the hospitals are a little more bound in how they're delivering the care. Other questions?
So yeah, I was sort of on that note, I was wondering about sort of like privilege and like is this kind of care something that really is realistically only available to people who are more affluent or have like better healthcare coverage, or save up to kind of cover whatever is not covered, or is it kind of also maybe if you're someone on Medicaid, then you're probably very low income. So I was curious if you could speak to that.
Yeah, I think I heard the question, which is accessing this type of services something more wealthy inclined people would be easier to access than those who are on the margins financially? Is that pretty good sum up? Yes?
Yes.
Okay. Yeah. So great question, right? And and I'm going to base my answer on the interviews and the people we spoke to, because that's I think the disciplined way to do is to sort of say, well, what did the data reveal on this important question you're raising? And I'd say, look, poor people, middle income people, they want to receive transition services as well, right? There's a lot of people don't feel like they're in their right body. I mean, it's the suicide rate is super high. So I didn't sense that this is just wealthy people that are seeking these services, and the people we spoke to, quite frankly, most were not. They are on the margins, but they mobilize, right? They do these things here. They get multiple jobs, they switch jobs, they take on debt, they mobilize to seek their care. And so it's not just sort of a wealth equals access story. It's more of a, people want these important services, and they're at different parts on the sort of socioeconomic scale, and they mobilize. So I think it's a very these services are broad, and they range from people who work in all kinds of walks of life. I would say that was our experience with the data that we collected.
Shauhin, this is Ted. Just a quick follow-up. You mentioned briefly intersectionality.
Yes.
Does the same hold true for race, immigration status, other markers?
So with regard to race, and we include in the paper, like, who we spoke to, how they self-identified, ethno-racial origin, all that. It seemed like people of color faced additional barriers, right, of racial discrimination and just sort of being dismissed in rude ways, in ways that just made it harder. Again, we didn't encounter a wealthy population. And so, I'd say these things are cutting across race, but those intersectional issues do elevate and make the experience even harder. I think that's the way to answer that. So there are challenges, right? But the challenges, become elevated when you face, for example, I think a couple people we interviewed wanted to change their name, and they were being challenged on their name and the ethno-racial origin of their name, and they weren't being given name changes, and that was making it hard for them to then access their care because they're claiming they're now female and they've changed their name, and they're still being given a card that has their male name. And so, all kinds of different issues there.
So you spoke about health plan.
I'm ready to relay. Go
Okay,
ahead.
don't think of this as well. Okay, so I've spent so many people in California are covered by insurance. I was wondering if this administration was any topic of employer-based inclusion of coverage.
So since so many people in California and I guess elsewhere are covered by employer-based health insurance, did you detect a pattern of coverage along those lines?
Oh, a pattern of coverage. So our other paper goes into, I think, private employers a little more. And I'd say we found, and among the private, we found sort of this, oops, sorry. We did find, I'd say definitely there's been a pivot in the insurance contracts to get rid of exclusions, categorical exclusions. And I think this did cut across the private employers. So that's good. But this is where I think the value of our paper is that doesn't tell the entire story, right? The devil's in the details, as they say, right? And it's sort of, you can say, in private employers and private insurance, they say we'll cover, or we won't exclude, but they exclude specific procedures. And so that's the kind of sort of coded language that's going on. And then, burying the coverage or the announcement of coverage in specific provisions. And so what we took away from it, and maybe you'll take away from it, is sort of things have gotten better, but there's a lot to get cleaned up on the ground if you want to effectuate the real lived experience of those seeking this care. And so when you see these meta debates, particularly that get shown, after things like Bostock v. Clayton County, and it's all over the news, it's painting the story as, oh, this is great victories, such and such and such. But when you dig in, you see it's a much more messy situation. And so I think private employers, private health insurers, and the relationship there, I think there's generally coverage, but there's still a lot of work to be done. I think that would be the takeaway. And until that work is done, you're going to have papers like this that show how tough it is and how the subtleties of medical necessity as a battleground, right? As a battleground, these kinds of things become the battleground.
I am curious about the relationship between these rules and these contexts and moral judgment, right? Because on the one hand, you could say, well, of course, insurance companies are always going to test what's medically necessary because that saves them money, right? And that this is just a money-saving story. But on the other hand, the direction in which they're contesting seems to be consistent with one of moral judgment. And so I wonder if you saw anything in your research about the relationship between those two things.
So, I heard most of it, and at the end you dropped your voice a little. I couldn't hear the key part. So,
I mean, did you see anything in your research about the relationship between those two, the economic motive and perhaps a moral motive that seem curiously to line up?
yeah, okay, got it. Great question. Yeah, this is evolving, right? I mean, I think this is an area that's evolving, and I think insurers are mindful that there's been a pivot in law, um, but they are also about profit, and and then there's morality, right? There's just a real morality here to be very rigid about things like, so an answer is there is sort of a morality is coming into play. On the one hand, law is pushing toward a raised rights consciousness of transgender persons and therefore their care. And so the paper tracks that, right? But there's politics, right? And so we can think about, sort of red states, blue states, and morality, right? And so this comes into play, I think, here, where you start to see these kind of rigid rules that on the one hand are neutral, but on the other hand, who do they impact heavily? Well, the transgender population who are seeking this care, right? And so it's a way for, I think, the morality and the uncomfortableness that maybe big business and insurance companies, of course, are big business, have potentially in these situations. And so they have these barriers, and they stick to these barriers, these rigid rules, and these rules impact a particular community more than another community, but they don't always change. And so I think I would view this as a snapshot and view this as a sort of a continuous battle going on and sort of push-pull. But I think things are moving in the right direction. But so it'll be interesting to see how this plays out, because this is the morality issue, the politics issue, and the law are all intersecting here. But this is where you see, hey, like, do we really need to be so rigid about age 18? Instead, following WPATH, which says 18, but there's discretion to account for the individual needs of the person. And that's what this person was talking about here, about that distinction. That's where I think politics and morality are coming into play, and possibly profit. Hard to tell. It was a great question. It's a hard question.
Other questions?
In your paper, you mentioned that there were some trans people who did not mobilize and go to disease. So I'm just wondering, based on the interviews, like, were you able to ask out what were some of the factors that led some to mobilize and others not?
Ted, I was having trouble hearing that one.
You mentioned that there were some trans folks who were led to resist and some who were not. And what did you find, if anything, were the factors that led a person from one category to the other?
Oh, great question. Yeah, no, that's a really good question, right? I mean, it's tough, right? Because every person is different, their story is different, right? But part of it is where you are in society. I think the more educated, the more time you have to fight. I think that was one, but a lot of the people we interviewed were more on the margins of life, and so that they're going to have less sort of time. They're more likely to just sort of try to do whatever they can here to make it happen, right? Whereas there's this more structural mobilization that's fighting the insurance company, working with nonprofits. I'd say that would be the biggest distinction that we saw. Is, do you have time? Do you have money? And do you have, the will? And the people who have less time, have less money, often have less will to play the long game and really contest, and might be more apt to give up or lump their losses or just try to muddle through and get the care you need in a system that is very hard to navigate.
Time for another question.
I'm keeping them from lunch, right?
Yeah, exactly. But I love doing that. I will ask one question and then I will announce lunch.
Okay.
We've seen in recent months, in particular around this country, a really disheartening pushback on trans rights generally, and on with respect to kids and what we're seeing, in states around the country. Has that you wrote this paper more than a year ago?
Yes.
Has anything that's happened since caused you to want to update or adapt any of the conclusions that you reached in the paper?
Yeah, and it's a great question. And to be even clearer, it's not so much we wrote, we collected the data, as we said, more like 2018, 2019, 2020. We write the paper in 2020. And then, of course, we go through the long peer review process when we publish it, essentially in January of 2022, and there's a long lag. So there's even more of a lag. I would say I don't think what's going on currently changes, our stance. I think with respect to sports, you're seeing this issue really flare up right now. The swimming, I'm sure you guys have read about this. I'd say context matters, right? That I started my talk with. There's a raised rights consciousness in employment, in sports, in healthcare, all these different areas. And so this is a deep dive into healthcare. One would want to do a deep dive into sports, right? As a different area to look at sort of what are the contestations there. But one could take knowledge from this paper and apply it in different contexts. So in other words, go look at, how are transgender policies with respect to athletics and sports, to what extent are they requiring a lot of rules, rigid rules that throw up barriers, would be one. How are specific terms and definitions, it might not be medical necessity, but it's going to be a different term. How are those terms contested by the people who are doing the implementing and the interpreting on the ground, right? So, law in the books, law in action, and this paper is all about the intermediary. The intermediary, that's where the action is. And therefore we can't always just look at the law in the books. We can't just look at the result. We have to look at what's going on in between. And so I'd say sports is probably different, employment's probably different, but you can use the mechanisms here, the mobilization mechanisms, individual, structural, interpersonal, and look how that is mobilized in different contexts. That's the way I would link my paper to current events.
All right. Thank you so much, Shauhin. It's wonderful to have you here with us today.
Thank you for attending.
Would you mind if I shared your email address with folks here?
Oh, please, absolutely. Absolutely.
Exactly that. Okay. Thanks so much, Shauhin.
Thank you all. Enjoy lunch.
There is lunch. It is East Courtyard, and on behalf of, and this is something I should have said at the beginning, the Center for Consumer Law and Economic Justice, CAPS, Public Health Law at Berkeley, and the Queer Caucus, thanks for coming.
Thank you so much. Thank you, Ted. Thank you, Ben.